How are you? We'll get started in just a second here. We'll let everyone call in. Happy Thursday. It's noon Eastern. We're delighted to have everyone on the call today. My name is Bob Miglani, and we've got Dr. Todd Cohan. Hi, Dr. Cohan, how are you?
Hi, happy Thursday, please.
Yes, yes. Hopefully, everyone got some rest after the elections. They slept. I don't know how late everyone was up, but I passed out about 10 p.m. I was out. We were traveling, so I had a little bit of a jet lag. So I fell asleep. But how's everyone doing? Hope everyone's doing well. Today we've got two wonderful people who are going to share with us some strategies about how to close and uh, closing techniques. Hi, Dr. Chapman. How are you?
Good. How are you?
Good, good. Nice to see you. Thank you for joining. So these two are really great people because they're really smart and they're always engaged. They're always happy to help. They volunteer their time to run Vision by Design, for example. Dr. Chapman had a wonderful conference recently and just spectacular. If you haven't been to VBD, you've got to go. It's an excellent place because it's such a core, diehard group of advocates who want to advance myopia management in America. It's a really, real great place to be. It's fun also. And of course, Dr. Cohan, expert on dry eyes, runs the Midwest Dry Eye Center, has a couple of practices in Illinois. And I got a chance to visit one of them and spend some time with him and saw some of the med spa stuff not med spa, but the room that he has for dry eyes, spectacular. And so he's going to share some strategies with us as well. So we're going to get started. If you want to just put yourself on mute, if you're not on mute already, it's going to be a short conversation today because we're all doing patient time and I want to be thoughtful of everyone's time. I developed a little bit of a slide deck, so I just want to share with you just a couple of quick slides that just set this up. And then we can kind of have a conversation if that's okay. Does that make sense? Great. Thank you. And if you have questions, drop them in the chat. The chat is open. It should be open. If it's not, I'll open it. I'll make sure it's open so that you get a chance to talk to everybody. And if it isn't open, just let me know. And well, you won't be able to let me know, but Hannah can let me know if it's open or not. Sending me a text or something. But is it open? Do you see it, Dr. Cohan, Dr. Chapman? Do you see the chat open on your side? You can chat on there. I just want to make sure.
Chat. Yeah,
Yeah.
it's open.
Okay, great, great, cool, cool. All right, perfect. Oh, good, it's open. Thank you so much. All right, so we're recording the call and we're going to go through it. We're going to share with you afterwards. And so let me just share a couple of quick slides with you. So set the agenda, if you will. So today we're going to talk about how to close dry eyes. And what I realized when I got into this business of myopia management and dry eyes and specialty care, that business as increasingly I see, is a game of psychology. And what we must do is to master our own psychology, our own mindset, and the way we think about it, and our language to help patients, as well as our language to help patients move forward and sign up. And so what I realize is that, patients used to listen to you as doctors. I went to my doctor 20 years ago. I listened to him and I was paying attention to what he was wanting me to hear about, to any instruction he gave me, I followed. But today, more and more patients listen to TikTok and social media than they do their own doctor. And the fault is not yours. It's just time. You're compressed with time. Typically, patients are spending 10, 15 minutes, maybe 15 minutes with their typical doctor. I don't know about optometrists, but in other fields, it's 7 minutes typically patients spend with their doctor. So how can you have a complex conversation about dry eye disease when you've got 7 minutes? And then you're competing with their phones all the time. And so one of the things, and by the way, if you're on just now, just mute yourself, please. And if you have questions, please. And so closing, when you think about closing, it really begins in the comprehensive exam. So you've got to have a strong language and effective language and thoughtful language in the comprehensive, and then the consultation, the ocular surface evaluation. And then the question is, what does that language look like? And one of the things I go to is the Bible for me of messaging, which is Don Miller's story brand, which basically what he says is no one cares about your solution, which is human nature, right? They don't care about you, they care about themselves. So we must talk to them about their problem. And so a lot of times I think Dr. Chapman and also Dr. Cohan talk about this is talk about, hey, we're looking at screens, we're not blinking enough. So it's really important to talk about the addiction that we have today, which is screens. And just a little anecdote, my wife was away on traveling, and so I was with the kids alone, the two of them, the third one's in college. And the 16-year-old daughter, she takes her dinner, goes to the dining room, which no one goes to, by the way, right? She's just alone in her dining room with her little phone. And it's always. And it's like her downtime, get away from everybody, I guess. And my 9-year-old son, he grew up with the iPad. And of course, when he cannot eat anything without looking at the stupid screen. Anything. So I put the TV on for him. And then I found myself, what am I going to do? What schmuck am I? What am I going to do? So I pull up my phone and watch Netflix. I watch Suits on Netflix, is my series now I'm getting into. And so I found three of us. I looked around, I'm like, what the heck is going on? I'm on Zoom calls all day long with my wonderful optometrists. And then I come home, I have like 3 minutes with the dog or whatever, say hello to the kids, hug, pour the dinner, and then I'm on my screen again. And then when I go to bed, of course, you're on your screen. So this addiction to screens is a real problem. And I think we need to really amplify that for patients and then simplify that language. And of course, use videos. And so videos, why? Because it gets everyone's attention. And then, one of the things I increasingly, I'll stop here for a second. And then is that increasingly all the research we've done is that people make decisions about healthcare after the kids are asleep in bed. Hopefully they're asleep at 9:30, after 9:30. And then the spouses are together. And it's like, hey, what happened to the doctor today? Oh, she told me I had something called dry eyes. Well, what does she want you to do? Oh, she said something about an IPL. It's literally, what's an IPL? Oh, it's some sort of treatment. What is it like? Is it like, oh, it's $2,000, $2,000? Oh, I don't know. Right? This is the conversation people are having versus, you want to have the conversation that's more on the line of, hey, the doctor saw me today and she said I had this problem and it's because of these screens. And therefore, like, what's she asking you to do? Well, I've got to go for a follow-up. Oh, well, you trust, I mean, he's a good doctor? Yeah, so you got to, well, go for the follow-up. That's the conversation you want to have versus the one about money and IPL per se, versus having a good relationship with the doctor. That's kind of the key point I want to make here is that most people, if you're conscious and you understand psychology of people, this is when they're making decisions. And it's really about trust and the bond that the doctor has that's going to help them move forward to a dry eye treatment. Now, let's go into our I'm going to stop sharing and we have a lot of people on the line here. So let's start with Dr. Cohan. Dr. Cohan, what are some techniques that can help the optometrists here on the call close dry eyes? Let's talk about the ocular surface evaluation, but also if you want to talk a little bit about what you say in the comprehensive exam so that we can understand the before and then the ocular surface evaluation.
Okay. What we do is during every comp exam, whether you're 6 or 66 years old, we're doing mybography on every patient because a picture says 1,000 words, right? So patients have a hard time understanding what it is unless they see exactly what's happening in their glands. And so what we do is we take a picture. I'll kind of say, doing all our pre-testing, we talk about the photos fields, all the stuff, the reason why we're doing everything for a complete, thorough ocular exam. And then we'll talk about the mybography. So these are your glands. I said we have oil glands that produce the oil. There's 3 layers of your tears, the oil, the water, the mucus. The oil is like the car wax that's being produced. And so what happens, we're on screens, we blink our eyes 70% less. So at that time, I'll say, these are the pictures of your glands. They should look like long piano keys. What do you think? And I have the picture, the J&J picture of the perfect glands, the moderate and the severe. Where do you think you fall in between those? And they usually point, and patients always like overjudge themselves where they think they're worse than they really are, just based upon the picture. I said, well, the picture is only one part of it, but it's how the glands work and function. I said, you're showing gland loss. Glands are like, it's not like a starfish that loses the leg and it regrows. I said the glands, once they're gone, they're gone. And the important part of this, you may not be symptomatic all the time. I said, did you know that sometimes people come in, their eyes are watery and they actually have a dry eye problem? The patients kind of like think about that. I'm like, well, no, it's about the quality more than the quantity, right? Most people have a quality problem. And so we'll just talk about that. I said, I want to be proactive. Just like if you have glaucoma, you're not going to come in saying my eye pressure is 32. right? You're going to tell me that we're going to find it. And so we want to prevent it from being worse. And so our practice philosophy is always being proactive rather than reactive. So then we kind of touch on that. Then we go in the regular eye exam and you're here for glasses, contacts, or whatever. And then at the conclusion of the exam, I said, okay, we're going to schedule it. It's called an ocular surface exam to further look into more depth as far as like how long it takes for tears to fall apart, inflammation, how well your glands work. So at the conclusion of the exam, I walk them up to the optical and I say, okay, let's take care of Mary's glasses for a computer or sunglasses or contacts, but let's make sure we schedule an ocular surface exam before she leaves. And that's the first thing the staff does in the handoff is they schedule that before they even go into the optical, right? Or from the optical, they do it. Then the ocular exam, ocular surface exam, we go through all the tests, the staff does everything. At the conclusion of the exam, we say, okay, this is the treatment protocols. This is like the standards of care. This is what we do. Eye drops don't fix the problem, so on and so forth. And then I'll pass them off to my patient education coordinator, and one of the staff will go over everything in terms of what we're prescribing, the IPL, the radio frequency, the LipiFlow, the BlephX, whatever the case may be, and we'll schedule appointments there from there. This is how our process works.
Gotcha. Thank you for that. Thank you. And then Dr. Chapman, is that a similar process or do you follow kind of a little different process?
I think it's similar in some ways. Every practice is a little bit different. So rather than being repetitive with what Dr. Cohan said, I would like to point out a few things that I'm very thoughtful about in my comprehensive exams. I think it's really valuable not to underestimate some of our inexpensive yet basic tools that we all have. Sodium fluorescein. Take that extra minute to put sodium fluorescein in the eye at the comprehensive exams, and MGS, meibomian gland secretions. The patient's looking up, you're under the slit lamp, pushing on that lower lid to see what their secretions look like. And I grade those in my notes on every single exam so that moving forward, I can look back and see if their secretions are changing after we've started treatment. I like to keep it very, very simple for the patients. I don't want to overwhelm them because we're doing a lot of other stuff besides just dry eye. And so I try and give them very little information and I try and give them real life examples. So when I'm in that comprehensive exam and I see that maybe they have SPK, which a lot of times you're not going to see unless you're putting in that stain, right? Or I see that their meibomian gland secretions are poor or moderate, they're turbid, they're chunky, like thick plugs. So I want to tell that patient, there's a couple of words that I think are key. If the doctor says, I see something that concerns me, the key word there is concern, because you want your patients to like turn on their listening skills when they hear that word. I see something that concerns me. And then I will say, I see signs that your eye is becoming too dry or you're at risk for developing severe chronic dry eye as you age. Okay, the patient can follow along pretty easily with that. I try to stay away from a lot of the science talk because I don't want to overwhelm the patient. And so then I will say, and this is what I want you to do. And I will liken it to dental hygiene often because they can follow along. And I'll say, you know how you brush your teeth every day, right? Or I might, if depending on my rapport with the patient, if we're trying to like joke around and be a little funny, I'll say, did you brush your teeth this morning? And they'll say, yes, of course. Did you wash your eyelids this morning? No. Like, oh yeah, I like splashed water on my face.
Yeah,
Okay,
yeah.
well, that doesn't count. All right, so I want you to start washing your eyelids every day, twice a day, just like you brush your teeth twice a day, every day. And in fact, we have some cleansing solution or some foam cleanser that we want you to use. And I want you to put it by your toothbrush. And every time you brush your teeth, I want you to wash your eyelids. And I think about it a lot, like how do we change human behavior? It is hard. So one of my favorite things that I learned some time back was the concept of habit stacking. If you attach a new habit, be it washing the eyelids, be it doing their Amsler grid chart, whatever, if you attach that to a habit that they already have, you're going to improve compliance. So that's number one. I would say I use the word concern so that they start listening. I tell them very simply how to attach it to something they're already doing so that we're helping improve compliance. And here's the third thing that I think is really important, Bob. I think it's very important to drive compliance for the doctor to not only recommend from the chair, but also to hand the product to the patient. I've spent hundreds of hours testing different ways to do this in clinic. And by far, the most effective method that I have found is when the doctor hands product to the patient. It improves the onboarding of patients starting to like leaving your practice with product from about 10% to over 90%. My rate right now is 94% at my clinic of my dry eye patients taking product home with them. So I have little dry eye boxes in my exam lane right next to my chair. And so when I'm prescribing to the patient, I'm telling them, I want you washing your eyelids. I'm pulling this box out of my little cupboard. So the patient sees that they're getting it from me. So that improves compliance a lot. And then this is a key. I not only want my patients to go home with product, I want them to get more product. I want them to start reusing the product. And when they run out, I want them to get more. I don't want them to say, well, I used the foam until it ran out. Right. I want them to say, well, I'm almost out. I better get more. Oh, and by the way, like we're calling them, like not me, not my office, but Peak, the company that I'm co-founder of. We have people at Peak who are calling these patients. We have workflows like set in place to send the reminder texts at that 28-day mark. Is it time to reorder? Because I don't want my patient to think when they're done with that foam, they're done. Like if you use up the last of your toothpaste, are you just going to wait until the next time you go to the dentist? Like you're going to go buy a new tube of toothpaste, right? Or have it shipped directly to your home with your Amazon subscription or whatever. So how do I get the patient in that workflow system? I need them to scan a QR code. So not only do I hand them this box, I also point to the QR code. And I tell that patient, and I need you to scan this QR code because it helps me track your dry eye treatment.
Gotcha. Now, do you do that, Dr. Chapman, in the comprehensive? We're talking about the ocular surface evaluation, or you're talking about the comprehensive visit? Do you?
I'm talking both, really.
Okay.
So I want to keep it very simple in the beginning. So at their comprehensive exam, I'm often, if I recognize a problem, I'm often starting the patient very light, as you say. I will start them on my dry eye box. Then you can kind of adjust it to where you're at, like what you want to prescribe as a first step. My first step is often foam cleanser, warm compress.
I see. So that's you get them in with kind of home care, and then, but what if you know, or you see that their glands are really poor? Do you then jump to the IPL or the RF, or like how do you know in the comprehensive visit which way to go, or is it just standard? I start everyone with home care.
Generally, I just start everyone with home care, and then I say, and then we'll see you back in 2 months, and we'll see how you're doing, and then it's time to like add on, right? Like you're adding a fish oil, or you're adding a recommendation for RF, IPL. Like I think patients need to be introduced to this a little slowly, because if you try and throw everything at them on day one, what I have found is they get overwhelmed and they just shut down. So we start pretty basic, that foam cleanser, warm compress. We start getting them into our Peak workflows. So they're starting to get these text messages that also like start to make them understand dry eye more. Like we kind of, like I know you use the term, like you drip information at them, right? So we're starting to just put them into this automated workflow where they're getting like, hey, did you know if your eyes are watery, that actually means that they're dry? Or hey, did you know that if you're doing this, this happens? Like, oh, did you know you blink 70% less when you're on screens? And so like that's really why I want to make sure I get all my patients scanning that QR code in the box, or I also have like little cards with QR codes in the room. And if I testing this, I have found that if I send the patient up front and the staff is the only one that talks to them about the QR code, the uptake of the QR code is close to zero.
Right.
But if in the exam room, I say, and I want you to scan this QR code today, guess what my acceptance rate is? It's like so close to 100% that you can round up. It's like 99 point something percent. And it's shocking. It's shocking
like the dentist used to
that
give
one
me
thing makes
the
a difference.
Yeah, no, it's like the dentist handing me the toothbrush and saying, hey, let me take this out. This is the rinse I want you to use. I'm like, yes, doctor. Like, okay, yeah, absolutely. It's that personal touch that goes a long way. So what happens if you don't want to go a little slowly that way, so start everybody home care. Let's shift a little bit, Dr. Cohen. What do you do when you have them come back for the ocular surface evaluation? They come back, you've done the tree breakup, you've done the diagnostic. How do you close the patients into the in-office procedure like an IPL? What do you do, Dr. Cohen?
What we do is, I'll talk to them. I'll explain everything, the technology about everything, and the reason why we do things, and according to all the research and things like that. And then what I'll say is, like, did you ever wonder what it'd be like if you couldn't wear your contacts for 10 hours a day, right? Did you ever think about, like, what if you had to put in eye drops all the time? Or, like, did you know that, like, prescription eye drops don't fix the cure of the problem? This is the root cause of your problem.
Mm-hmm.
I said, this is why we want to be proactive. This is why dry eye is a disease that is chronic and progressive if you don't do something about it. So we'll talk about the different treatments, and then we'll set up a protocol. And then I'll have my patient education coordinator go through that. The staff is just as well versed as I am in terms of the same verbiage and messaging when it comes to why is this not covered by my insurance, can I make payment plans, so on and so forth. So they have all the same verbiage that we all use throughout both practices to ensure that the patient gets rid of those questions, and we can make zero interest payment plans for patients. And so what we'll do is we say, look, this is something you don't want to get it worse. You don't want to watch it till it gets worse. And then let's go ahead with the treatment. And the patient education coordinator will schedule things. They'll schedule the 1 day, day 50, all the different sessions and things. And then we'll see them back accordingly based upon what they're doing. So
gotcha. Yeah. I mean,
we have a very high close rate with the ocular surface exams. We're probably, with having their treatment scheduled within 1 month. Now people are traveling and so on and so forth. The summer is always slower because people in Chicago want to enjoy the summer while the sun's shining. And, there's some contraindications with IPL because of that. So, but I would probably say we're north of 80% in terms of like our follow through with the treatment protocol.
Gotcha. So let me just walk this back a little bit. Let's rewind for both Dr. Chapman, Dr. Cohen. So I'm a patient. I'm sitting in your chair. It's the ocular surface evaluation. For Dr. Cohen's case, in Dr. Chapman's case, it's a 2-month follow-up after I've started home care. Okay. And then you've done your testing, done tear breakup. You might do inflammatory. I know, Dr. Cohen, you like that. I'm not sure if Dr. Chapman, you do that. But, and then you look at the glands, you do my biography again. And then you say to me, okay, Bob, I would like to prescribe an in-clinic procedure. I think you're eligible, or I want you to do this procedure, RF, IPL, etc. Right? And then, so you're saying that, and then you hand over to your coordinator. But between the saying that and giving it to the coordinator, do you talk about the fee? Do you talk about versus like drops? Do you talk about or is that your patient coordinator address that, Dr. Cohen? And then we'll talk to Dr. Chapman.
Okay. So what I say is like, look, I say, when patients will ask me how much it is, I'll say it's around this price, but we package everything together so you have an upfront savings, because this is the complete package of taking care of the inflammation and the gland function, right? So I tell patients, look, this is my verbiage. I always say, look, you could be on Restasis or Xiidra Cequa, and 80% of our patients no longer have to take those regularly, right? And those are going to run you $70, $80 a month out of pocket forever, and they don't fix the underlying issue. Insurance, if they were smart, they would take care of these treatments and help pay for that, but they didn't cover mammograms either for 30 years, right? They could have saved so many people's lives. They're cheap because the majority of patients can't afford $70, $80 a month forever, and they're getting over-the-counter eye drops, Sustain, Refresh, you name it. And that's over a $2 billion industry. And just like insurances have no idea how much money we spend on Advil at Target, they don't know how much we're spending on eye drops. And so the thing is that, you could stop taking those Restasis tomorrow, or you could use it 100 times a day, and your glands will still look like garbage, and they're not going to improve, and they can still keep dropping out. So that's kind of the verbiage on that. And so we'd rather do something naturally, get your glands working without pharmacology, prescribe it at-home treatment. We do a lot of Dr. Chapman's, like, educate to the dental model. Ocular hygiene is no different than brushing and flossing. Same thing with your ocular hygiene, very important for inflammation, dry eye symptoms. And so that's kind of how we kind of relate it to the patient.
Gotcha. Thank you. Dr. Chapman, talk to us about your script, your language to move them forward into an in-clinic procedure such as an IPL or talk to us about that.
Okay, so when I'm talking about IPL and RF, I like to rely a little bit more heavily on that mybography scan at that point. And I will point to the patient's scan and I will say, this is what we're concerned about. I don't want you to lose any more glands. Our goal is to save what's left to keep you from developing severe dry eye as you get older. And I will often have them sent, like before their visit, they will have received those Hoot videos for the dry eye, so that they kind of have a little bit of a background on what the IPL and the RF are. And then I will tell the patient basically, I'm recommending these for you. This is the best thing that we can do for you at this time to help prevent progression. And I like to use that word concern. I'm concerned if we don't intervene now that you're going to progress. And I have, in my clinic, we have it set up as like a monthly subscription. And so the patient can sign up. Year one is a little bit different because they're doing like their series of treatments that are very close together. And then year two and beyond, it's more of like a maintenance contract. But they can pay it like where we just keep 2 credit cards on file and we just run those cards every month. And that affords them a certain number of treatments. It's all laid out in the contract. And then we just get them on the schedule and kind of keep them going. And I like it that way because I feel like there's a little bit of a difference when you're signing up someone for those initial treatments where they're doing it, every 2 weeks or whatnot, versus when you've kind of transitioned away from that and now you're wanting to do quarterly treatments on these patients. And so I think it's nice for the patients to see that. And I have a care coordinator in my clinic that has a lot of the conversations with the patients so that it doesn't take as much of my time. But I think it's nice for the patients to kind of see it all spelled out, all laid out. So they already in their mind are thinking after they're done with year one, they're already starting to think, oh, I'm going to be able to do like quarterly after so that I don't ever get to the point where I have to do the whole series again.
Yeah. And then so when you start them into home care, lid hygiene, with Peak Wava, and you start with that, is there expectation that lid hygiene will solve their gland problem when they come in? And then is it hard for you to then transition them to an IPL? Or
No, not at all.
like, no, right? It's kind of like home care plus this other
Home
thing.
care plus, yeah. Think of the good, better, best model.
Right.
Like good gets you so far, better gets you further, best gets you even further. And then like adding in IPL-RF is like platinum. It's
Right.
kind of like, think about it this way. There's so many different analogies we can look at. Let's say somebody is told by their doctor that their blood sugar is high and they're maybe like borderline diabetic and they try diet and exercise first. If that doesn't work,
Yes.
they start insulin or they, whatever. Like, okay, we've started these at-home therapies and that's helping a little bit, but it's not getting you all the way to the finish line.
Right.
This is our next step. Or like with Demodex. Okay, so you still have eyelid mites. We tried the at-home foam cleanser. I need you to keep doing that because that's going to help keep it at bay, but it didn't get you close enough to the finish line. Now I'm going to start you on XDEMV. And by the way, keep using your at-home foam cleanser. It's just like when you go to the dentist and they clean your teeth professionally, but then you're also brushing your teeth every day at home to help keep that plaque to a minimum.
Yeah. No, I like the example of the blood sugar and certainly cholesterol. Anytime you go to a doctor, it's the right thing to do when the doctor says, "Hey, Bob, stop eating burgers and start exercising," right? Like do that. And hey, it didn't help. I mean, obviously compliance, we're terrible. Human beings are really terrible at compliance when it comes to home care. So eventually, yes, you're going to need the statin or the other, therapeutic that's important. So I think establish your credibility. Now, let's talk here. So a lot of us on the call here have an instrument like an IPL or RF device. And one of the challenges we have is not feeling confident enough. And we might not have the staff that's trained properly, Dr. Chapman, Dr. Cohan, like you have. And so what do you recommend to the doctors on the call here? So the concern is a good language to use. insurance doesn't cover it. So proactively mentioning that, I think, is very important. Like Dr. Cohen said, I think it's, one of the things I learned, and learned it from, my wife and a lot of other, like yourselves, is that you almost have to be a mind reader when you do close. And what I mean by that is that when they're sitting in a chair, they have something in their head when you're speaking to them, and you kind of get it out, right? By get it out. And so the bridge phrase I like to suggest you think about is, hey, you're probably wondering, does insurance cover this, doc? Right? So just say that then, because I think it's really helpful. So what tips do you have, Dr. Chapman and Dr. Cohen, for those of us who are like, okay, I'm about to prescribe or recommend my, $100,000 instrument that I bought, and I need to get that patient to move forward to do that because they've done all these other things. So the concern, being proactive. Is there anything else, like, for example, should we talk about the, IPL versus drops strategy at that point, or is that handled beforehand? What are the other things that you could say that could push them to the edge of moving forward in treatment? So give us one or two tips. Dr. Cohen,
Go
you
ahead,
want to?
Cheryl.
Yeah.
Go ahead. Oh, okay. So just, the thing is, like, just being proactive, talking about why you want to do this. You don't want your glands to get worse. In quality of life, those types of things is kind of what we hit home with. But
Yeah.
you have to have conviction in the process, and you have to make sure that all your staff is into the process and your mission behind of why you're doing it.
Yes.
Right. Our staff knows, they're not thinking that, every IPL is a dollar sign. They're thinking about, this is the best treatment we're providing for patients. And they also know that we're a thought leader, that we're doing things different than other practices, which is why a lot of our staff is happy that we're to do those problem solving that other patients, the average patient goes to 3.2 offices before they find the right dry eye doctor. So the staff has to have conviction in that, and they can do subtle mentioning. Like, we had a patient the other day, she came in from another ophthalmologist. This guy was kind of a knucklehead, and don't care for him, but she's in our office now. And our staff, I complimented one of my office staff members. She goes, well, Dr. Cohen's on the forefront of all this technology. The reasons why we're doing this is the process. Our patients do great with it. And patients like to hear, Bob, how other patients' experiences have been, right? I'll be like, oh, most of our patients say that their eyes feel so much great. Like, we're on our second or third iteration of people having LipiFlow in our practice, right? When we first had LipiFlow, there wasn't IPL and radio frequency. I said, look, every single patient that's had LipiFlow the second time or third time, now they've had a conjunct with IPL. They say, oh my gosh, my eyes feel so much better immediately, because we've taken care of the inflammation for a couple of treatments beforehand. So they like to kind of hear testimonials from other patients. I think kind of helps they're not just like this person, this island, this problem, that, other patients have gone through the same process also.
Yeah.
So that kind of helps too.
And Dr. Chapman, do you think that when you close and you have your care coordinator, how well versed are they with dry eyes? I mean, you have, a large number of staff here in your practice. Is it important to get them involved so that because a lot of times when you walk down the hallway with the staff person, patients are like, hey, should I get this? Is that something that sort of comes up? And how do you deal with that proactively to get the patients to sign up?
Well, I really liked what Dr. Cohen said about having conviction. You do have to make sure that, like, you don't come across as wishy-washy, and you have to make sure your staff believes in it as well. And one of the best ways to do that, I think, is to provide dry eye treatments for your staff.
Right.
Whether or not they recognize that they have dry eye, the chances they probably do, because as Dr. Cohen probably has recognized as well, the vast majority of people have dry eye. So I think providing those treatments for your staff members can help them understand it more. For me personally, I am a dry eye sufferer. So I often will tell patients, I do these treatments to myself. I do these treatments so that I can wear my contacts. And so I think when the patients hear that, oh, you understand, or, oh, you do this as well, like, that makes a huge difference. I think another important thing for doctors to think about is, if you feel a little uncomfortable when you're talking to patients because you feel like sometimes doctors feel bad asking patients to spend a lot of money, first of all, forget that. Like, it's the patient's decision.
Yeah.
you're giving your best recommendation. But I think when doctors do feel a little bit uncomfortable, they tend to talk too much.
Yes.
They tend to, instead of just like saying what they need to say and like, hard stop,
Yeah.
they just kind of keep going, and they need to break that habit. Just say, this is my best recommendation for you. This is the best thing for your situation.
I love that.
Whether it's, I mean, when I used to do a lot of, KOL dinners for contact lens companies and things, we'd always sit around the table with these doctors. I'm like, everybody should be 80 to 90% daily disposables. It's the healthiest for the patient, the best for the practice. Let the patients decide what they want to spend money on, right? Let them give up their $6 Starbucks a day to have more money for contacts. Show the value and the importance and your professionalism, exactly what Dr. Chapman was saying, and then put it in their court. They'll find out a way. Let them try them. Daily disposables are twice as much revenue. The patients come back once a year, and it's healthier for patients.
Yeah.
Check, check, check. Any other questions? So let the patients decide what they value and how they want to kind of foresee things without doing these things, and see how things are. But Dr. Chapman's exactly right. They talk themselves in circles. Oh, discount this, discount that, and be the nice person. Patients are coming to you for professionalism. The fact that you have invested into your practice speaks volumes into the patient. Patients aren't thinking, oh, Todd's got to do these machines to charge me up the wazoo for these machines. No, they're knowing that we're increasing our level of care. We're staying on top of things, and they appreciate that. And that's why they keep coming, right? So.
Yeah, that's absolutely right. Just as a pause for a second, anybody have questions, please put in the chat now. Very soon, these two wonderful doctors are going to have to go back to seeing patients. So please ask your questions now, okay? Okay, so I have a, anecdote here. So I had a doctor recently, and she said to me, Bob, my patients, I have trouble explaining money and pricing, and I'm afraid, I feel bad, charging, to exactly your point. And I said, well, do they have poor glance? Yes. Okay, great. And so tell me your demographic. She said, well, it's mostly women. I said, I know women in some ways. I have married to one. I have two daughters. I have a team full of women. And I do know one thing about women, whether they're young or, they get their nails done. Okay. And I asked my team recently how often, women get their nails done. It says 6 times a year or so. And how much are nails? It's $100. It's $100 with tip or whatever. It's maybe 120 or something. So we're talking about $600 to $800 being spent on
what about hair coloring?
nails.
What about hair coloring too?
We can go on and on and on. The question becomes, what is it that you value is what you're going to pay for. And if your doctor, who you have a good relationship with, who's demonstrated her or his expertise to you and said, look, I think this is really a problem. It's not like I'm making it up. So the myography is there. You're doing the secretions. Dr. Cohen's doing everyone's doing the myography. You're showing their scans like a dentist does, right? Says this is an objective clinical assessment of your eyes. You're starting with home care thoughtfully, and you're saying, look, I think this is an important treatment for you. I want you to go ahead and not spend thousands of dollars getting Restasis and so on over the next whatever few years. So I think that is an opportunity to take that money piece out of your head, and really, because just take it out of your head and give as much value as possible. So we have a question here from someone here. So the question is the following. Do you find that patients are more inclined to sign up with a monthly payment option or a lump sum? I suppose, Dr. Chapman, since you brought up the monthly payment, maybe you can take that in time, Dr. Cohen, if you talk about that.
I have found that patients are more likely to sign up with that monthly payment option. We do also offer care credit, but I found that for whatever reason, patients really don't like always going to care credit. They feel icky about it sometimes. But when they know that we are the ones that are we're kind of like helping finance it. And then, the concern could be, what if they default on their payments? Well, I mean, we do require them to keep 2 credit cards on file. So that if one doesn't go through, then we just run the other one through. And it's been a really nice way for people to spread those payments out. It makes it hurt a little bit less. And they can handle it a little bit more easily.
Yeah. So just to give an idea, I don't want to share exact amount, but Is it like under $100 per month, or is it a little over? Like, give us
It's more.
okay, okay.
But it covers a lot. So
Yeah.
for us, that first year is more expensive because they're getting more treatments because we're doing every 2 weeks IPL-RF. And then after the first 4 treatments, then we do a single, like a month later, we do a single RF. We're also including, we have our Peak Pro boxes that we give them we have an IPL box. So that is like a peptide cream and a hyaluronic serum, and like, so it's got extra, more like bougie skincare type stuff that they're getting as part of that. But even when they go into year 2, it's still a little bit more than $100 a month for them to get those quarterly treatments. But if you think about it, each of those treatments individually, if you're doing both IPL and RF, you're getting like you would spend a lot individually on each of those to do them quarterly.
Yeah, totally get that. Thank you for that. Dr. Cohen, do you have have you tried monthly? I don't know. Do you do monthly, or how do you do?
Yeah, we offer payment plans. If we say like, look, it's this much up front. If you do a prompt pay, we'll take off whatever, a couple $100 or something. But we'll do the same thing as Dr. Chapman. We store their credit card securely, 0 interest. Like the other day, I had a patient, single mom. Her glands are looking. She had LipiFlow 3 years ago. Time to have it again. I'm like, look, Judy, I don't really care how long it takes you to. I want you to have this done. I said, you can pay me over 6 or 9 months. And it was just LipiFlow only. She couldn't afford the other stuff. But so what? Over 6 months, she's paying $100 something a month, whatever, or more, whatever. But for the LipiFlow, but I'm like, I'll give you a discount because it's the second time having it. But I care more about when you show the compassion to patients that I care more about you having this done than paying me right away. It shows them that you're caring about their clinical outcomes more than the financial. You'll get the money eventually, but do you sometimes get shorthanded because they cancel that credit card? Yes, but very rarely. That's why we keep 2 credit cards on file and things like that. So
Actually, perfect. Thank you for that.
yeah, it works for patients. They're so used to paying for Netflix every month. It's like
They are.
We do for a lot of our
They pay for
myopia
Netflix and
patients.
Hulu and Peacock and Apple and Disney Plus.
Yes.
All of it.
Well, I think I've looked at this, for our business model as well, and at Hoot, but and there was a challenge. We did monthly plans, and then we did one. We split it up into two plans, and then we have a monthly option as well. So we've been all over the place, but we looked at this very carefully. And it also in myopia as well. And what it seems to be the case is that when people don't feel they're getting the service or the touch or the love, then they complain about it. Meaning if it's a monthly thing and they're not using it, and then it's like occasionally you scan the bill and you're like, what is this? I haven't seen I haven't gotten any value from it. There's no attachment of value. So in the case, if you're doing the monthly plan, you've really got to have them on that schedule. And that's why I think the Peak, boxes are helpful. They're getting in, and then, Dr. Cohen's got, the staff reaching out, or they're coming in more frequently. It sounds like both of you are doing packages. And if you're doing packages, then it absolutely makes sense because you're going to see them. And therefore, it shouldn't be like, oh, you got to give me $1,000 now and another 3,000 at this time or 2,000 at that time. That's a heavy check to bring, and they probably won't show up. So, so I think spreading that out absolutely makes sense. So it really is dependent on what you're offering. And in some cases, if it's a straight old-fashioned IPL at $400, for 4 sessions, okay, maybe 2 payments should be okay, I suppose. I don't know. I mean, that's something you might want to think about as well. So any other questions, any other thoughts that you want to share, Dr. Cohen, Dr. Chapman, as we close up in the next 1 minute or so?
I think just having a process is important. Outline your process, just like you outline steps to make a peanut butter jelly sandwich. Outline your process for how you're going to attack a dry eye patient when it comes in for the screening, to the talk points, to the ocular surface exam, to the conversion, and have all your staff abreast of those processes. I think that's the biggest thing that most people fall short, and that's why their IPLs or LipiFlows or RFs become coat hangers,
Dr. Chapman, anything you want to add?
I would also like to say, practice your verbiage. And if it's not working, try different verbiage, because with different things that I've done in the past, whether it's converting all my monthly lens wearers to daily disposables, or talking to patients about myopia management, or instituting dry eye. Over and over again, I found that you really just need to find the right words. It's amazing how you can adjust people's behavior by just talking to them slightly differently. And it can make all the difference in the world. It can change your conversion from 10% to 90%, like that. So if what you're using isn't working, just try something different. And the more you do it, the better you get at it, and you'll figure out what resonates. But just keep doing it, keep doing it, keep doing it. Don't be afraid.
Excellent. Thank you.
I
for that.
love what Dr. Chapman did when she was saying her percentages earlier. Most people don't know their practice numbers, let alone their conversion numbers for dry eye and specialty services. And being able to track and measure those things, like Adam Schmela from his podcast says, what gets managed gets measured, right? And what gets measured gets improved. And so basically, you cannot, like Dr. Chapman had great percentages based upon, look, this wasn't working, let's try this approach. But do a thing. You know, we talk to doctors like, oh, LipiFlow doesn't work. Well, you tried the worst patient in the world and a study of one. You can't do a study of one, right? You hear that from all these different doctors. Oh, it didn't work. Like, you have to figure out your processes, manage it. So if Dr. Chapman, what she probably does, and that's what I'm going to start doing now, thanks to her, is like, let's look at our conversion. Let's look at the verbiage. Let's look at our process. If that's not working in a 2-month spread, let's try doing something else. Let's do maybe more Hoot dry eye messages. Let's do more point of contact emails, things like that. Let's see if we get a bump, because you have to always look at your processes. Just like any factory looks at their efficiencies, you have to do the same thing in your practice, and looking at your practice as a business and a system is very important.
Yeah, that's actually super powerful. I want to leave you with this. Yeah, sorry, go ahead, Dr. Chapman. Sorry.
I think too, I just want to point out that we at Peak, we work with a lot of offices where I think the doctor expects the staff to be leading the charge a little bit. The doctor just says, well, staff, you take care of this. Office manager, you take care of this. And what they really need to understand is that they have to be the ones that are doing key parts of that process that Dr. Cohen's talking about. The doctor does have to understand what's going on. They have to understand the role that they play, because if they aren't doing the right things, they're making it very, very difficult for their staff to be successful. So the doctor does have to play those certain key roles. And like I said earlier, the doctor has to be handing product in the exam room, and the doctor has to be the one saying, scan this QR code.
I think that's absolutely right. I think having that personal touch. And by the way, Peak, just so others may not know about it, where do they find info? Is it getpeak.com? Is that what it was, Dr. Chapman? Or
peakpro.com. That's PEEQPRO.com.
Excellent. Excellent. Thank you for that. I just want to share as we close, just some things I learned in sales that might be helpful to you. You have to be, and I talked about this before, you have to be a mind reader. And so it's really important when patients are sitting in a chair to bring up the objections. And so the bridge language I just mentioned before was, you're probably wondering, hey, doc, why can't I just use drops? Hey, doc, why should I do an IPL when I don't feel bad, right? I don't feel anything. Hey, doc, does insurance cover it? And doc, is it worth the money? So these are questions or objections patients often have that's in their mind, but they're not going to tell you. They're just not going to sign up. And so the way you do that at the close is to bring it up. You say, hey, you're probably wondering, and then just say that, and then answer that question thoughtfully. Because it just teaches the patient that you've done this before, and that this is a standard of thing. This is a standard of care, and that you know how to answer those questions. And it makes them feel assured, rest assured, that they're signing up. The last thing is just give them permission, which is, I think Dr. Cohen and Dr. Chapman did it really well, which is like, look, your glands are not great. This is the right decision for you, and give them permission to act. Patients love when a doctor is clear and tells them what to do, because that is the doctor's expertise. The patient is not the expert. I'll just leave you with this one anecdote. My wife was away, and I took my son, 9-year-old, to the dentist. This is the youngest of our kids. And first time, okay? 8 cavities. The guilt I felt, I felt so bad. And the dentist was like dancing around, and kind of making recommendations. And she's a friend of my wife's. And I said, Dr. Simmer, please just tell me what I got to do. I have a very busy life. Please. Is it my credit card you need? Tell me what I got to sign. Just do it. But don't like, I'm like, I don't want you to dance around because I know you're trying to say it's going to be very expensive. Okay. All these cavities, right? But I don't care. Just, I want the truth. And in our busy environment, patients want clarity from you. So as Dr. Chapman and Dr. Cohan here have spent so much time eloquently explaining to us is be confident, be poised, be articulate, use the right language, and then just tell them what to do because they need you to do that. You are the white coat and they're counting on you. So thank you very much for your time, Dr. Chapman, Dr. Cohan. Such a pleasure to have two rock stars with us today. And I hope all of you found this useful. We'll share this video on social and all the good stuff and on your platforms. And I wish you the rest of the day. Have an amazing day. Thank you so much, Dr. Chapman, Dr. Cohan. Bye, everyone.
Thanks.
Have a nice day. Thank you. Bye.
Bye.